Do you know that something sitting in your medicine cabinet right now, something you may take without even thinking twice, could be quietly raising your risk of a heart attack or a stroke? I'm not talking about anything illegal, anything exotic, or anything you need a warning label written in red to notice. I'm talking about ordinary medications, the kind millions of people over 60 reach for every single week, for pain, for allergies, for sleep, for symptoms that feel completely unrelated to the heart. And yet, when researchers and the FDA have looked closely at what actually happens inside the cardiovascular system of someone over 60 taking these medications regularly, the findings are sobering enough that I think every person in this age group deserves to hear them clearly and without exaggeration. Before I go any further, I want to set the tone for this entire video because what I'm about to share is medical information, and medical information deserves to be handled responsibly. I am not a doctor, and nothing in this video should be taken as an instruction to stop, change, or avoid any medication you are currently prescribed. What I am going to do is walk you through 5 categories of medications that have real, documented associations with increased cardiovascular risk in people over 60, based on research from sources like the FDA, the American Heart Association, the Mayo Clinic, and peer-reviewed medical journals. My goal is simple. I want you to walk away from this video informed so that the next time you pick up a bottle, whether it's something from your pharmacist or something prescribed by your physician, you know the right questions to ask. If anything here applies to you, please bring it to your doctor or pharmacist directly. They know your full history, your other medications, and your specific risk factors in a way that no video ever could. Let's start with the one that surprises people the most, because it's sold without a prescription and sits on nearly every drugstore shelf in the country. I'm talking about NSAIDs, which stands for non-steroidal anti-inflammatory drugs. This includes common names you've almost certainly used yourself, like ibuprofen, sold under brands such as Advil and Motrin, and naproxen, sold as Aleve. It also includes prescription versions like celecoxib, diclofenac, and indomethacin. These are the medications most of us reach for when our back hurts, when our knee is swollen, when a headache won't quit, or when arthritis flares up after a long day. They feel safe because they're so familiar. But here's what the FDA actually found. Back in 2015, the agency took the unusual step of strengthening an existing warning label on these drugs, stating that the increased risk of heart attack or stroke can begin within the very first weeks of use, and that this risk climbs higher the longer you take them and the higher the dose. What's even more important for people over 60 to understand is that this risk isn't limited to those who already have heart disease. The FDA was explicit that these drugs can increase the risk of heart attack or stroke even in people without any prior heart condition or risk factors. Researchers estimate the increased risk ranges anywhere from 10% to 50% or more, depending on the specific drug and dose involved. And here's the detail that matters most for this age group specifically. Between 10 and 40% of adults age 65 and older use prescription or over-the-counter NSAIDs on a daily basis for everyday pain and inflammation. Because of natural age-related changes in how the kidneys filter, how the heart pumps, and how the body distributes and clears medications, older adults are simply more vulnerable to these cardiovascular side effects than younger people taking the exact same pill. The mechanism behind this is fairly well understood. NSAIDs increase the tendency of blood to clot, and clot formation inside arteries is the central mechanism behind most heart attacks and strokes. On top of that, they cause the body to retain sodium, which can raise blood pressure and worsen heart failure symptoms in those who already have them. If you take an NSAID occasionally, for a headache or a sore shoulder for a day or two, the research suggests the risk is genuinely low. It's the regular, prolonged, higher dose use that the warnings are really aimed at. If you find yourself reaching for these every day, that is exactly the kind of pattern worth discussing with your doctor, who may suggest the lowest effective dose, the shortest possible duration, or an alternative like acetaminophen, which has not been linked to this same cardiovascular risk, though it carries its own separate caution around liver health at high doses. The second category brings us to something almost everyone has used at some point during a cold or allergy season: decongestants. This includes pseudoephedrine, often sold as Sudafed, and phenylephrine, found in many combination cold and flu products. These medications work by constricting blood vessels, which is exactly what relieves that stuffy, swollen feeling in your sinuses. But constricting blood vessels in your nose doesn't happen in isolation. These drugs act on blood vessels throughout your entire body, which means they can raise blood pressure and increase heart rate at the same time they're clearing your sinuses. The American Heart Association has been direct about this, stating that people with uncontrolled high blood pressure or existing heart disease should avoid taking oral decongestants altogether, and that even people with lower cardiovascular risk should use them only with guidance from a healthcare provider. For someone over 60, this matters more than it might have at 30, because blood pressure tends to climb naturally with age, and a large portion of people in this age group are already managing hypertension, often without even feeling any symptoms day to day. Layer a decongestant on top of that, and you can push blood pressure into a riskier range without ever realizing it's happening, because you'll likely just feel like your cold is clearing up. There's also a documented case literature on pseudoephedrine causing more serious cardiovascular events in elderly patients, including irregular heart rhythms. And researchers have specifically flagged that age-related changes in how the body processes this drug make older adults more susceptible to its side effects. If you're over 60 and you reach for a decongestant during cold season, it's worth checking your blood pressure if you can, watching for symptoms like a racing heartbeat or unusual anxiety, and asking your pharmacist about non-stimulant alternatives like saline nasal sprays, nasal steroid sprays, or antihistamines that don't carry the same blood vessel constricting effect. The third category is one that quietly affects millions of women specifically, and that's menopausal hormone therapy, sometimes called hormone replacement therapy. I want to walk through this one with real care because the research here is genuinely nuanced, and the headlines you may have seen over the years have often oversimplified it. Hormone therapy can be a meaningful and even protective option for many women, but the timing of when it started and the age at which it's continued changes the risk profile substantially. Multiple major studies, including the well-known Women's Health Initiative trial, found that the cardiovascular risks associated with hormone therapy are significantly higher in women who are older or who start treatment many years after menopause has already begun, compared to women who begin treatment closer to the onset of menopause itself. Specifically, research has shown that menopausal hormone therapy raises the risk of ischemic stroke in women over the age of 60, even though that same increased stroke risk isn't seen in younger women starting therapy near the time of menopause. The risk of venous thromboembolism, a serious blood clotting condition, nearly doubles in women aged 60 and older who are on hormone therapy, with the highest risk occurring in the very first year of treatment. Some studies examining women starting hormone therapy later in life found as much as a 50 to 80% higher risk of coronary heart disease during that critical first year, a risk that does tend to decline as treatment continues, but that represents a real and serious initial spike. This is sometimes referred to by researchers as the timing hypothesis. The idea that starting hormone therapy within 10 years of menopause or before the age of 60 carries a very different risk profile than starting it later. If you are over 60 and currently on hormone therapy or considering it, this is precisely the kind of nuanced, personal decision that deserves a direct conversation with your physician about your specific cardiovascular risk factors, the formulation you're using, oral versus transdermal, and how long you've been on it, because the route of administration alone can meaningfully change the level of risk involved. The fourth category might be sitting on your nightstand right now, and it's one that catches a lot of people off guard because it doesn't feel like a heart medication at all. I'm talking about diphenhydramine, the active ingredient in Benadryl, which many people take not just for allergies, but specifically as a nighttime sleep aid. Here's what the research tells us. Diphenhydramine belongs to a class of drugs with strong anticholinergic effects, meaning it blocks a particular neurotransmitter throughout the body. In older adults specifically, this can cause confusion, urinary retention, a significantly increased risk of falls, and cardiovascular effects, including a racing heart rate, irregular heart rhythms, and in some documented cases, changes visible on an EKG, including widening of the heart's electrical signal and conduction disturbances. The American Geriatric Society has gone so far as to specifically name diphenhydramine in what's called the Beers criteria, a widely respected list of medications considered potentially inappropriate for adults age 65 and older, precisely because this population tends to experience reduced kidney function, age-related sensitivity to anticholinergic effects, and a higher likelihood of taking multiple other medications that compound this same risk. Beyond the more immediate cardiovascular concerns, longer-term studies have also linked cumulative, regular use of anticholinergic medications like diphenhydramine to an increased risk of dementia, with some research showing the highest risk in those with the heaviest cumulative use over time. If you're over 60 and you've been relying on Benadryl or a similar over-the-counter sleep aid most nights, this is genuinely worth a conversation with your doctor. Safer alternatives exist for both allergy relief and for sleep, including non-sedating second-generation antihistamines like cetirizine or loratadine for allergies, and approaches like melatonin or cognitive behavioral therapy for insomnia for sleep specifically, both of which carry a far smaller risk profile in this age group. The fifth and final category brings us to opioid pain medications, the kind prescribed for moderate to severe pain following surgery, injury, or chronic pain conditions that haven't responded to other treatments. Chronic pain affects an enormous portion of older adults, with some estimates suggesting 60 to 75% of people over 65 live with it in some form, which is exactly why this category deserves honest attention rather than fear-based avoidance. Researchers studying a large group of community-dwelling older adults without any prior history of heart disease found that those who were prescribed opioids had a 67% higher likelihood of experiencing a cardiovascular event, including heart failure hospitalization, heart attack, or stroke, compared to those who weren't taking opioids, even after adjusting for other health factors. A separate large cohort study following nearly 30,000 adults over several years found that prescription opioid use was associated with an elevated risk of cardiovascular death. And interestingly, this study found the risk was particularly pronounced in women. Researchers at Yale, who published some of this work, were careful to note that this risk appears to exist independently of the more widely known dangers of opioid misuse and overdose, suggesting there may be a direct physiological effect on the cardiovascular system itself, separate from any addiction-related concern entirely. This research is still evolving, and to be clear, opioids absolutely remain medically necessary and appropriate for many people managing severe pain, particularly after surgery or in cancer care. But for someone over 60 managing chronic ongoing pain, this research suggests it's worth having an honest conversation with your physician about the lowest effective dose, the shortest reasonable duration, and whether non-opioid pain management strategies might be appropriate alongside or instead of opioid therapy, especially if you already carry other cardiovascular risk factors like high blood pressure, diabetes, or a family history of heart disease. So let's bring all of this together. NSAIDs like ibuprofen and naproxen, decongestants like pseudoephedrine and phenylephrine, menopausal hormone therapy in women over 60 or those starting it later in life, diphenhydramine used as a sleep aid, and opioid pain medications. 5 categories, all widely used, all genuinely helpful for the conditions they're designed to treat, and all carrying documented cardiovascular considerations that become more significant specifically after the age of 60, when the body's baseline cardiovascular risk is already higher and its ability to process and buffer these medications has naturally changed. I want to leave you with the same message I started this video with. This is not a call to panic, and it is absolutely not a call to stop any medication on your own without talking to the person who prescribed it to you. Stopping a medication abruptly can carry its own serious risks, sometimes greater than the ones we just discussed. What this is instead is an invitation to become a more informed participant in your own healthcare. Bring this list to your next doctor's appointment. Ask specifically about your individual risk factors, your current medications, and whether safer alternatives might make sense for your particular situation. The goal isn't fear, the goal is awareness, because awareness is what allows you and your doctor to make the best possible decision together for your heart, for your brain, and for the years ahead. If this video gave you something valuable today, please consider subscribing because I cover topics exactly like this one regularly, always grounded in real research and always with your safety as the priority. And if you know someone over 60 in your life, a parent, a spouse, a friend, who might benefit from hearing this, please share this video with them. It might start an important conversation they didn't know they needed to have. Thank you so much for spending this time with me today, and I'll see you in the next video.